Hi everyone, it's 7 p.m. Central European time, and we are getting ready to start this Liver MRI webinar, which is the third one in the series, which we are able to provide thanks to our sponsor, Bioradiology Nordics, who is sponsoring this interesting and yet very successful educational event. And to date, we have done 2 webinars. This is the third, and our plan with this webinar series is to create this initial spark of interest to get engaged in the liver MRI space. So we've seen attendees ranging from the seasoned radiology resident to the subspecialized abdominal imaging radiologists here. So everyone, if you are a radiographer or a clinician or everyone else who is non-radiologist, please feel more than welcome to this session today. For those of you who registered, you were also able to get access to these cases that's being discussed on Collective Minds. And for those of you who's not familiar how to access the cases, I will just show you this very, very briefly before giving the word to the lecturer of today and introducing the faculty for today. So I'm now sharing my screen. I'm logged into Collective Minds Radiology, and all of you who registered and accepted should have received an instruction how to log in and how to access these cases yourself with your own user account. Basically, when you're logged into Collective Minds, you will be able to access this Liver MRI webinar series from the top menu called Groups. And if any one of you having issues to access this, please just write us in the chat, and me or my colleague Seidel will help you out. I see we have Darren here as well. So we're a team from Collective Minds who is here tonight to support that, and if you need any support with the DICOM viewer meanwhile, just write us in the chat and we'll take care of it. So when you're inside this group, you will see that you will be able to access the webinar recordings from the previous sessions in December with Dr. Tomer, the overview of MRI imaging of liver tumors. We got the second webinar from February with Dr. Tomer and Dr. Maya Kuipers on the MRI protocol and the use of contrast agents. And tonight, we have the pleasure to introduce Professor Maxime Renaud from Paris, who will be lecturing on benign liver tumors, an overview. To access the cases, once we have completed the brief introduction lecture, you click this MRI cases, and it will take you to a page which is a case collection or a playlist of these cases. So Maxime, you will toggle through the cases in the prescribed order, case 1 to 4. And when you're on this list, you can simply click open review mode to get into the case. And from here, as you see on the left-hand side, you got all the available series. You can easily drag and drop one of them into this space. Select windowing, for example, to change the windowing of this. Move to the next series, and so on and so forth. So with that introduction, I would also like to welcome the previous lecturer, Martin Tomer, along with Professor Maxime Renaud. So Dr. Tomer, Professor Renaud, most welcome, and the stage is yours, Maxime.
Thank you very much, Frederick. Hello, everyone, wherever you are in the world. I'm very happy to be joining you tonight to discuss benign liver lesions. And I thank also Martin Tomer for chairing this session and Collective Minds for setting up the technical possibilities for us. So I will be lecturing very briefly about benign liver lesions, and then I will be discussing with you interactively about the cases that I've posted on the Collective Mind platform. So I chose to focus on a specific context that is quite frequent in the liver, which is the fortuitously discovered lesions. And I did that because when you look at the prevalence of the different types of focal liver lesions in the general population, you see that by far the most frequent ones are hepatic cysts and hepatic hemangiomas. So the prevalence that are reported here may be subject to debate, but it's estimated that around 10% of living adults do have at least one focal liver lesions. Now, when we discuss the other type of focal liver lesions, for instance, the focal nodular hyperplasia or the rest, then we see that more than 97%, sometimes 99% in some series of fortuitously discovered lesions in the liver are benign. So tonight we need to discuss benign lesion, and this context is quite a good one to discuss that. Even if we know that the context is very important, and in general, we will see that fortuitously discovered lesions are discovered in young patients without any specific symptoms. We need to bear in mind that the clinical context is very important. And this is an old study, but I like this one because it's a study of patients with a history of cancer. And when we look at those patients, we see that around 13% of them had indeed focal liver lesions. So you would expect those lesions to be more malignant because of the history of cancer. But in fact, only 12% of those lesions were actually metastases. So even in patients that have a high risk of malignancy, we have a vast majority of benign lesions in the liver. And it's interesting for us to keep those figures in mind. So the context I was discussing is very frequently this one. It's a young patient, often a female patient, possibly taking estrogen-based oral contraception, and the patient has very often no medical history, no complaint, and for any reason, she or he undergoes a liver ultrasound that shows a focal lesion and or possibly as very mild abnormal liver tests. Now, when you do an ultrasound, I know it's a liver MRI webinar, but still we need to remember that some of the lesions, especially the most frequent one, can be safely diagnosed with ultrasound alone. On the left-hand side, you see the hepatic cyst, very easy to diagnose when typical. And also the small hemangiomas, and if you follow the European guidelines, you can diagnose them confidently if all the features are present. But since we're discussing a liver MRI webinar, we need to move forward, and frequently the MRI is recommended as a second-line examination for the characterization of something that has been found on ultrasound. Now, we talk about MRI because MRI is really the better exam to do this characterization of any kind of focal lesion in the liver. So it's very appropriate. So let's start by the very frequent one. When you see something that is bright on T2, that is very bright, it's a cyst, and you've been taught to recognize those lesions quite easily because you know they're homogeneous and bright on T2. They might be lobulated and often multiple, which is an interesting feature in favor of the diagnosis. You've been told that there will be no inner septa or nodule and no contrast uptake. Now you can see actually some very thin peripheral septa sometimes, then they will raise from the foot of the lobulation. So this is not something that should frighten you, but no contrast uptake is very important. And MRI actually is very good for everything that is fluid containing in the liver. So when you have those typical cysts I just showed you, it's easy. You know very well also the typical appearance of the multiple biliary hematomas that appear as a starry sky, that's those bright spots on heavily T2 sequences. If you zoom in and you focus on one of them, sometimes you will see that there is a mural nodular or remnantment. So this is not something that should scare you. If you have a very good exam, you can see that. And MRI is also very interesting to analyze the content of the cyst, and much more than CT, for instance. For instance, on this one, is just a very large solitary cyst. You see it's hypo on T1, no enhancement, and bright on T2. It's interesting to rule out complication and also to differentiate those large cysts from any other possible cysts that may be, for instance, parasitic cysts. So here MRI is very good, but also ultrasound, especially contrast-enhanced ultrasound, should be considered as a good complement to MRI. And this is one example where the MRI was really better than the CT. You see that this cyst seems to be quite homogeneous on CT, but on T2 weighted imaging, you see that there is this inner septation that are very consistent with the diagnosis of a parasitic cyst, an edetic cyst. And aside from the T2 content, the T1 also is very interesting and can help us depict or suspect the presence of inner bleeding, especially when the patient reports sudden pain. And here you can see that this very bright on T2 cyst shows hyperintensity on T1 that is consistent with an history of bleeding. And if you were to perform an ultrasound to this patient, you would see those very typical mobile inoseptation that are predominant at the periphery and move like algae in the cysts, especially if you move the patient. So this is not to be considered as a sign of malignancy. And if you inject contrast, you should know that when there's been inner bleeding in a cyst, progressively there will be an inflammatory reaction around the granulation tissue around the cyst. So you may see some peripheral announcements, and you should not mistake that for a tumor, because you see that all the tiny septations inside, they actually do not show any contrast announcement. And if you have a doubt, you can move on to contrast ultrasound. That is a good complement, I must repeat, to MRI. And then when you see no announcement on the septation and the nodules, it's safe to say that it's not a tumor. But when you see some, like in this case here, and you see on the left bottom of the slide the announcement of the septa, then you can suggest the diagnostic of mucinous cystic tumor. But this is beyond the scope of our lecture, because we're now focusing on benign lesions. So if it's not a cyst, but it's still very bright on T2, you know that the second candidate is an hepatic hemangioma, hyperintensity on T2, but lower than the CSF, and also homogeneous on T1. And you have this very, very peculiar peripheral nodular discontinuous announcement that will progressively and centripetally fill the lesion in. So those lesions here are very, very easy to diagnose. And you should also know that when you use the diffusion weighted imaging sequence, although the lesion is very, it contains a lot of fluid, you should not expect the signal to drop progressively with increasing B value. It's actually the other way around, due to something called the T2 shine-through effect. So the majority of hemangioma will actually show high signal intensity on IB value diffusion, but the ADC map will be very helpful to get the proper diagnosis, as you can see here on the right-hand side. And it's also quite interesting to know if you have a very tiny flash-filling hemangioma, because sometimes it will mimic the presence of other type of enhancing lesions. For instance, take this lesion here on the right lobe, enhancing on T2. Well, it could be an hemangioma, could be something else. It's visible on T2, but do not panic. If you look at the ADC map, you see that it's quite high value, and this is very suggestive of the diagnosis. And we will discuss that during the case. You see that this association of enhancement, hyper T2, and high value of high ADC value is very suggestive of a vascular lesion. When the lesion is very big, so sometimes called a giant hemangioma, frequently, and this is very suggestive also for the diagnosis, you will see the inner hypo-T1 septa and areas of high signal intensity, even higher than the rest of the lesion. This is something that is very, very frequent in large lesions. And in those large lesions, actually, the vast majority of them will show the typical enhancement, so the diagnosis is quite easy. Be careful if you use gadoxetic acid, because this is a patient with a small hemangioma that has a typical presentation with extracellular agents. But if you use gadoxetic acid, you should know that on hepatocellular phase, the lesion will appear hypo. So if there is the partial filling before that, it's okay. But if you go to a patient with a very slow filling hemangioma, for instance, or in patient in a context of peculiar cancers, it might be a pitfall quite difficult to solve. So it's not always easy to diagnose when you lose the very late stage of the enhancement with gadoxetic acid. Now, in real life, when you have a focal lesion and you ruled out cystic lesions and typical hemangiomas, then you can suspect the rare tumors that actually are the hepatocellular lesions that we love to talk about in webinars and congresses, but actually quite rare in real life. So when should we suspect those? Well, to suspect those, we need to remember that they contain two things: normally differentiated hepatocytes and numerous abnormal arterial vessels. And this will translate for us on MRI as a very interesting feature that is called the arterial phase hyperenhancement. That is common to all hepatocellular lesions. Now, it might be homogeneous or not, might be different from one patient to another, but this is a very important key feature we'll be discussing during the case presentations. Now, if we start by the first one, actually the most frequent one, the FNH, you know that it's a rare lesion. Vast majority of them are found in young female patients. There is no relationship with estrogen-based contraception. You know also that the complications are extremely rare, and that a vast majority of patients have solitary lesions. This is a very interesting one because this is a lesion that we can non-invasively diagnose with imaging, pending all the features are present. And when I say all the features, I mean if you see a lesion that is homogeneous and lobulated, with a signal that is close to that of the liver, marked hyperenhancement on arterial phase, as you can see here, no capsule, progressive fading with the rest of the liver, and the famous central scar that is hyperintense on T2 and shows progressive enhancement, then you know it's an FNH. It's the combination of all the features that can help you diagnose that. Now, when we use liver-specific contrast agents, we can add another feature that is the ISO to hyperintensity on epithelial phase, very sensitive and very specific when considering the selected patients. And you can see here two examples with gadolinium bopta on top and EOB-DTPA on the bottom line, very, very suggestive of the diagnosis. And this hyperintensity may be homogeneous, but also frequently not, and the center of the lesion will be hypo, and sometimes you will only have a peripheral rim of contrast uptake. This is also something that you can see in FNH, and the diagnosis is cool. Two frequent atypias I think you should know about. The first one is the presence of fat in the FNH, as you can see here on the bottom row. So if everything else is present, you should not change your diagnosis. And it's okay to see an FNH containing fat. After all, it's made of hepatocytes. And the second one that is more tricky is the presence of a mild washout that is present in, let's say, 5 to 10% of patients in CT on MRI. And it's more frequently observed in patients with hepatic congestion or hepatic sinusoidal dilatation. Every time you have a doubt, you should go to another exam or ask a friend, go for a biopsy, or sometimes use contrast and ultrasound that will show you the very typical central vessel spoke wheel pattern and no washout. And this is especially true if the lesion is peripheral and small. And finally, if we do rule out everything that we discussed before, we can consider the hepatocellular adenomas. So I will not be discussing those today, just to remind you that they are extremely rare and they're to be considered a family of tumors. They are associated with various risk factors, including contraception. And Martin Tomir will be discussing that in a further webinar, everything else. The only thing I need to maybe say tonight is that one key element is the differentiation between FNH and adenoma using liver-specific contrast agents, because we can see that while FNH retain the contrast, the majority of adenoma will not and show hypointensity. Okay, so to summarize my very practical take-home messages for you, first of all, remember that the context is very important, and you need to exclude liver diseases and extrahepatic cancer to safely diagnose the most frequent benign lesion. And remember that 99% of them are benign when found by chance. Tooth hemangioma, very frequent. You know by heart the typical enhancement pattern, but be aware of fast filling and fibrotic forms, and caution when you use liver-specific contrast agents. FNH, look for the typical features. All of them need to be present, and also know the possible value of the additional feature that is hyperintensity on a epithelial phase. And finally, do not hesitate to biopsy, do not take to and with that time in attention, and I can now answer some question or discuss some cases. What do you think?
Maxime, we were losing you a little bit in the end here. Could you repeat the final points you made?
Oh, you didn't hear the final one was the number 4.
Yeah,
sorry.
number 4. Yeah.
The number 4 was don't hesitate to biopsy the lesions, and do not hesitate to ask for help It's very nice to have a network of experts, of friends that can help you when you have a difficult case.
Super. Thanks a lot. Thanks a lot. So we will open up for some questions in the chat if there are any. So please feel free to write some questions in the chat. Martin Tomer will moderate this. So if there's any question now, feel free to post it in the chat. Otherwise, we will move on to the case-based session.
Okay.
And so regarding the case-based session, we will post now a link in the chat to everyone. If you're logged into Collective Minds, you can follow along the cases yourself using this link.
Okay, so that's not the
so
one.
we had one question. We had one question
Yes?
in the QA. So how does focal infiltrative steatosis present on MRI? Can it show some reticular enhancement in between the fat suppressed areas?
So I guess that you're talking about focal fat deposition in the liver. If it's not correct, please correct me. It will present. So of course the fat will show signal drop on opposed phase T1. Okay, that's very common to any fat-containing lesion. We can think about the fatty infiltration, as you say, or focal fat deposition, when we see that it is located in specific areas of the liver, especially around the gallbladder in the posterior part of the segment 4, for instance. And this is due to vascular changes around this area. And another thing is that when you have focal lesion containing fat, focal benign fat deposition, you will see that most of the time the fat will be predominant at the periphery. And yes, you can see some perfectly normal liver in between the lesions. One key element is that the vessels and bile duct will go through the area completely unchanged. And if you use an ultrasound, or if you do contrast enhanced ultrasound, you will see no difference on contrast enhanced ultrasound with the rest of the normal liver. There is another one about that, how to differentiate focal fatty changes with some retained contrast from FNH with fat. Well, it's not always easy, and one of the key maybe difference is the presence of this arterial phase hyperenhancement I discussed, because it's very marked and lobulated in FNH, and we'll see one case. Whereas in focal fat deposition is more frequently lower and not that lobulated.
Yeah, one final question.
How can we confidently diagnose hemangioma in a cirrhotic liver? So hemangiomas in cirrhotic liver are rare, and we don't really know why. And we think that's because they shrink during the progressive deposition of fibrosis. We know that they're rare. We know that they tend to be smaller than in patients with normal liver. And we also know that, well, they're quite typical too. So hemangioma in cirrhosis is rare and small, but most of the time will show the typical presentation, especially the typical announcement. So you can diagnose hemangioma on FNH. Of course, every time you have a doubt, you need to be extra cautious because it's a very peculiar context. But it's very often possible to diagnose. So how would you differentiate multiple liver cysts with piliosis hepatis? So that's an interesting question, because actually piliosis hepatic has very different presentations, both in real life and in cases. Could be focal, could be multiple. But most of the time, it's not, the differential are not cysts, are more enhancing lesions or heterogeneous lesions. So I would not discuss cyst versus piliosis. I would discuss vascular lesions or tumors or pseudotumors versus piliosis, rather than cyst, for instance. Keep asking questions if you want, and I will start reviewing the first case. But I will answer your question on the fly if you have more. Maybe you had a chance to look at this first case, and when I open a liver case, the first thing I ask myself is, do we have signs of any form of chronic liver disease, whether it is a fibrotic liver disease or a vascular liver disease or a biliary liver disease? And that's the first thing you need to ask yourself all the time. And if it's not the case, well, you will have a allegedly normal liver. So we talked today about benign lesions. So I choose only normal livers, but I would just like to remind you that that's the key for the differentials. So on this first case, maybe you saw what seemed to be a focal lesion here in the segment 8 of the liver. Here you can see it. It's a little bit, it's hypo on T2 compared to the liver. And when you scroll on T1, you will see that the lesion is iso. Here you can see that iso intense to the liver. So it's interesting because not a lot of lesions are very iso to the liver. If you look at the diffusion weighted imaging, which is a poor one, and I apologize for that, you will see also that the lesion is impossible to differentiate from the liver, and the ADC map is the same. Okay, now when you move on to the arterial phase, you see that the lesion shows very marked arterial phase hyperenhancement, as you can see here on this arterial phase, and you have another arterial phase that can show pretty much the same. So it's quite interesting. So this discrepancy between marked arterial phase hyperenhancement on one end and something that is not really visible or very hard to differentiate from the liver on non-contrast sequences is quite suggestive of an hepatocellular lesion. This is not something you will see in other forms of lesions. So it rings a bell, looks like an hepatocellular lesion. Now, this lesion is rather large and is very markedly enhancing on arterial phase. And you can see that it's slightly lobulated. It's not a very round lesion. And I would say that the enhancement on arterial phase is quite homogeneous. So I said, though this lesion has a lot of features that point at an FNH. So now the problem is that we did not really have the central scar that is very important for us, supposed to be hyper on T2 and hypo on T1, and progressively enhancing on contrast enhanced sequences, sorry. And then if you look at the portal venous phase, you see that the lesion is hypo compared to the liver. So there seems to be some mild washout. So I think we had a poll. Do you want to start the poll?
Absolutely.
So there was one poll. I don't know if I can see this, but
yes. Okay, here comes the first poll. So everyone, feel free to submit your responses.
Yeah. So the first poll is, what do you think the most likely diagnosis is at this point? Do you think it's an HCC, an adenoma? Do you think it still is an FNH, an angiomyolipoma, or an hepatic hemangioma? So you can vote. I don't know how long.
Yeah, we're getting responses now. So let's give it maybe 10, 15 more seconds.
Yeah, okay.
Yeah. 45% participated so far. So that's good.
So one thing I might have shown you, yeah.
Okay, so I think we're concluding the poll here. We got
and I will
more than half
the results with you.
There we go.
Okay, so that's actually logical and very good. So the majority went for either an adenoma or an FNH. And that's okay, because we said we have a lot of arguments, we have a lot of features favoring the diagnosis of hepatocellular lesion, but there is some problem with the FNH. The problem is that there is no central scar, and we still see this mild washout. So it's a problem. It might be something we see in an adenoma, of course. Angiomyolipoma, I should have showed you the in and out phase imaging, and I will. Here it is. So, and you will see that there is no fat in the lesion. If it wants to go down, here is the in phase. This is the out phase. You see no signal drop, so no fat. So angiomyolipoma may contain a low fat quantity, but still. HCC could be, but still, again, the context matters a lot. So I would rule this out. And the hemangioma, we cannot say that because we don't have the peripheral discontinuous announcement. So now I will show you the late phase that would perform with liver-specific contrast agents. And you can see that lesion shows this signal. It's very, very, very bright on hepatocellular phase. And the second question was, maybe you can launch the second question. So can we use this new feature, ISO hyperintensity on hepatocellular phase, to confidently diagnose FNH if we don't have all typical features? You could say yes, you could say no, you would say depends. So, okay, let's vote. What do you think?
Okay, it's good. The polls are coming in. Okay, soon we're past 50%. Very good. It's a very interactive crowd today. That's great.
Good. Thanks.
Yeah. Okay, we got 61%. So let's close it there.
You can show me the results. What do
there we go?
See, that's interesting. It's almost one third. I like this because it's a very frequent question. It's a tough one. So it's true that we have no study demonstrating or showing that we can replace one missing feature with this new one. So technically, I cannot say that every time you have an atypia and you see hyperintensity on hepatocellular phase, it's an FNH. It's not true, especially because other lesions, rarely HCC or adenoma, may sometimes show this. Okay, so I would be cautious.
Could you show me the T2, Maxime?
Yes. But and that's a fair point. But then you need to move on to the other sequences and ask yourself, well, these other sequences, what are they favoring? And everything was a lot in favor of FNH, except maybe this one was. So this hypointensity is very strange for an HCC. Would be quite strange for an adenoma. So I think it favors an FNH. Also, mild washout, I showed you, was possible. It's possible in FNH, especially when you have liver vascular lesions or sinusoidal dilatation. And it so happens that this patient actually had one. And if you go to the arterial phase, you can see some degree of. So I said this is the heterogeneity that sometimes you see that corresponds to sinusoidal dilatation. Go scroll the case in yourself, you will see that. So if it was me that was diagnosing this case, I would think that we have more in favor of the diagnosis of FNH rather than adenoma. But in your practice, if you see a lesion like that, you should move on. You should go further and say, okay, I think it's an FNH, but I'm not 100% confident. Let's do a biopsy. It's okay. So the question was, why is it not an HCC?
No, the question is what should you do if all the signs are typical for FNH, but there's only washout? Would you do a biopsy or not? What is your what should be your advice? Is there a reason to do a biopsy if there's only washout as a worrisome sign? Okay, so if I conclude, you would not do a biopsy if there's only washout, but there are typical signs. The other signs are typical for FNH, including a scar. Then you would not advise a biopsy. Is that what you wanted to say?
Yes.
Okay. Okay.
We are going to move to the second case, case number 2. And this case is going to be a bit trickier, but still we're going to talk about benign lesions. And I would like to focus on the one that is on the left side of the liver, because the patient had a self-palpation of an abdominal mass. And you see that here, the lesion is bigger, a bit heterogeneous. So for now, don't look at this one, just look at this one. It's a bit bright on T2, mildly hypo on T1. And if we go to the other T2, we see that it's also a bit a bit brighter than the liver, but not that much. Okay. If we go to in and out phase, you will see that there is no signal drop out, so there is no fat in the lesion. And then when we go to the arterial phases, we see something that is also very interesting. It's this marked arterial phase hyperenhancement. And the lesion is actually more lobulated than we thought, especially here on this side. And the lesion is, while it's a very big lesion, it's a very homogeneous enhancement. Now, if you compare to the lesion on the right, you see the differences, because look at this one. This one enhances quite heterogeneously. This one is really brighter on T2. And this one is also more hypo on T1. So we see differences between the left and the right. The right seems to be more hyper on T1 and T2, and the enhancement is heterogeneous. If we go to the portal venous phase, we see that the lesion on the right has more enhancement than the lesion on the left, especially on the delayed phase. So what we see here are actually two kinds of lesions that behave completely differently. And the first one on the left actually has a lot of features that looks like the previous one. It's hyperenhancing, homogeneous and lobulated. And if you look at the late phase, you see that we see some septation, some lines inside that seem to enhance progressively over time, and we're not really seen on arterial phase. So it seems that this is fibrous enhancement pattern, and those areas actually correspond to areas of hypo-intensity on T2. Now, I know that when we discuss an FNH, of hyperintensity, sorry, on T2. If we discuss an FNH, we always want to look at the central scar. But when the lesion is very big, the central scar is either frequently missing or is not at the center of the lesion, is frequently more peripheral. So for instance, we can see here that those bright on T2 scary appearance that we see here actually are not exactly at the center, but more peripheral, but they show the progressive enhancement that we expect in an FNH. So this big lesion was actually a large FNH, and it's quite fairly typical because we have all the features. And you can also very well see the difference between this lesion and the other one. The other one is another type of hepatocellular lesion, but it's an adenoma, and I'm not going to discuss this today. Martin will in the next webinar, but it's nice to see the difference between an FNH and an adenoma. FNH can be slightly hyper, but not as much as the adenoma. It's the other way around on T1 weighted imaging. The enhancement on arterial phase is very different. And the way it behaves on later phases is also quite different. And if we move on to the late phase, we see also this very, very important difference. The adenoma is hypo, and Martin will tell you a lot more about that next time. And you see that this lesion show iso to hyper intensity on hepatobiliary phase. And you see that all the thin lines that showed progressive enhancement and we thought corresponded to fibrous septations or area inside the lesion, they actually are hypo and hepatobiliary phase. And look at that. You see this area looks like a central scar, actually do not retain the contrast as much as the rest does. And that's also this, I don't know how we can describe that, this brain-like appearance is very, very in favor of the diagnosis of FNH.
Maxime, I have a question. Could you comment on when you would use Primorist?
Yeah.
Then the hepatobiliary phase is on 20 minutes. The scar will be dark, as it is in this case with multi-hands.
Yes.
But how the transitional phase, will the scar be hyper-intense or hypo-intense? So in the late venous phase, Will it act
So
the
if
same
you,
as with
yeah,
multi-ends?
so if you use multi-ends, it's going to behave like an extracellular agent. So the scar will be hyperintense on the late phase. If you use Primavist, the transitional phase is a bit different, and there is frequently still an hypo-intense scar. So if you have a Primavist, you will kind of lose the typical appearance of the central scar in a significant subset of lesions. And the scar is already hypo because the lesion has a signal that increases so fast that the contrast between the lesion and the scar is in favor of the lesion. So the scar will be hypo.
In the venous phase, okay.
Yeah. So someone says, why does the fibrous scar of FNH not retain contrast? It does if you look at here, for instance, it does if you look here. But on the hepatobiliary phase, it's not that the scar does not uptake the contrast. It does, but significantly less than the normal hepatocytes around. So the amount of contrast in the FNH is so high that even if the scar has maintained some of the contrast agents, it seems to be hypo because there's less contrast than in the normal FNH around. I hope it's clear.
What are the differential of hyperintensity in the hepatobiliary phase using multi-hands?
Well, actually, everything that will uptake the contrast and keep it will be hyperintense using multi-hands. So it's pretty much the same thing as for Primavist. So the differential will be some HCC in a very specific context, some adenoma, and you need to think about that when you look at the lesions. But here again, both the context and the appearance on the other sequences will be quite different and will point at those differentials. So did you launch the first one? The first
Would you follow up? Oh no, okay.
Sorry, go. While they
no worries.
When the audience is voting, I can answer the question or hear your comments. No, but my question was unrelated to this case, but related to FNH, and it's a very frequent one. A question that I'm asked a lot is when we found an FNH in a man, what should we do? Should we biopsy always to confirm the diagnosis? Should we do exactly the same thing as in women, actually? Should we think that everything we know, especially the appearance on hepatobiliary phase, is not reliable in men? And do we know that if there is a risk of complication that is higher in men than in women? So what do you think? So maybe we can see the result.
94% say it's similar.
Great, and I think that we have a very, very good audience tonight because they're right. 94% of the voters are actually right. The diagnostic workup is similar to that in women. The appearance is the same. The reliability of the features are the same. The complication is the same. Everything is the same. It's just that because it's rare in women, in men, we need to be extra cautious when we diagnose this non-invasively. We really need to make sure that we don't have liver disease, that we don't have anything that will change the probability of FNH. But if all the boxes are checked, the diagnosis is the same and the confidence in the diagnosis is the same. So bravo. Can you share some references to understand the benign and malignant lesion on MRI in cirrhotic? Yes, I can, and I will send that afterwards. After the end of the webinar, I can send them, and I'm sure that's we will find a way to share them with you.
Absolutely.
I have another question for you, Maxime. I don't have the answer for it, but how come that FNH do not exist in cirrhotic livers? Why don't we see any FNH in cirrhosis?
Yeah. So So this is there's a bit of a debate within the pathologic community, because some pathologists do believe that you can find FNH in cirrhosis. So
that are pathologists.
I would, sorry?
That are pathologists particularly who are saying that, but as a radiologist,
yeah, I know that and I know it's very, very super rare. I personally think that it's extremely rare, if not non-existent. And when we see an FNH in a liver, it's frequently a special form of liver, for instance, vascular liver disease. In that case, you can see FNH in strange cirrhosis-like liver. But in purely cirrhotic liver, I agree that we have case reports, and I actually do not really know why we don't see them.
Okay.
I guess that they don't develop, but I don't think they disappear. So I don't really know why we don't see them.
Okay.
I think I can comment on the third case, and I will not have time for the fourth one, but if you can scroll the case at home and then send me the comments or anything, and I will be happy to answer via email. So this is a case of a very large lesion in the liver. And the lesion is here on the right liver, is hypo and quite homogeneous on T1. And if we go to the T2 weighted imaging, we see that this large lesion here is bright. So it's not as bright as the CSF, but quite bright. And we see something I discussed during the lecture, which are those thin hypo lines within the lesion and the areas that show more intensity than the rest of the lesion. So this feature itself is very, very suggestive of the diagnosis of hemangioma. So now we need to see whether or not our INCH is good. And to do that, we move to the diffusion. And I told you that the vast majority of hemangioma have a T2 shine through effect. So I expect the lesion to be quite bright on IB value. And look, it's the case. You see that the signal intensity is not homogeneous, but you see that the signal is bright, so it's okay. And if I go to the ADC map, which is very poor, but still, you see that the value is higher than that of the liver, so it fits. And then we need to move on to the contrast and phases. And on arterial phase, I would expect the lesion to show peripheral discontinuous enhancement, which it does. And then time, minute after minute, as time goes by, I would expect the lesion to progressively get filled in by the contrast. So this is the first arterial phase, the second arterial phase. If I have a third one, I will show that the contrast is even bigger, and so on and so on. And if I go directly to the late phase, I will see that the lesion is more filled in by the contrast. So it's so big that it's not possible to wait enough for it to be completely filled by the contrast. But still, we have everything we need to diagnose an hemangioma. And this association between high signal intensity on T2, high ADC value, arterial phase hyperenhancement, and progressive enhancement over time, the association of the three is very suggestive of a vascular lesion. Okay, so it could be benign, like an hemangioma, but this association is very in favor of vascular lesion. Vascular, by which I mean a lesion that raised from vascular cells and not hepatocytes. Okay, so it's fine. But one thing that was interesting in this case is that around, if you look at the lesion, it seems to be here. But if you look at the rest of the liver, and for instance here, the left lobe, it seems to be different from the large hemangioma, but not exactly as it should be if it was a perfectly normal parenchyma. Look here on the right. This is a normally expected signal for the liver parenchyma, but here it's brighter. So the shape of the liver is perfectly normal. It's not distorted, and we can see the vessels inside. So everything seems to be fine, but there is more intensity on T2. There is also less intensity on T1. You can see here. So if you look at this large area in segment 4 and the left lobe, that is different from the large hemangioma that is around the large hemangioma. And if I go to the contrast and sequences, I see that there is this heterogeneous enhancement on arterial phase, okay, marked enhancement, but respecting the shape of the liver, and progressively the lesion will also like get filled in, or the intensity will get brighter and brighter over time. So it has all the features I told you that were in favor of a vascular lesion: bright on T2, high ADC value, and I could show it to you because you could see that here. Look, it's brighter than the rest of the liver, plus enhancement from the arterial to the late phase with a progressive increasing signal intensity. But it's not a focal lesion. It's a liver, but that has the appearance of a vascular lesion. So I do not know if you already witnessed that, showed that in your patient, but this is something that is often visible around very large hemangioma. It is an infiltrative form of hemangioma tissue mixed with the hepatocellular normal cells. So it's an hemangiomatosis around a large hemangioma. It is not worrisome. It's absolutely benign. It's actually kind of exactly the same as an hemangioma, but just not well delineated. It's an infiltrative form of hemangiomatosis around a large hemangioma. It's been well described. So when you see that, not only should you not panic, but it should be one additional argument for you in favor of the diagnosis of a large hemangioma, okay? And there's nothing to do, no biopsy should be performed, and you can be very reassuring with your patients.
Thanks a lot.
I have a question about the growth of hemangioma. So we have studies, but let's say from surgical teams, evaluating the growth of hemangioma to around 3 to 4 millimeters per year in diameter. But it's very different from one patient to another. Can you grow 30% in 1 year? I mean, I've seen that. So in my experience, it's possible, but you should be really careful when you diagnose that and ask yourself if it really is not possible to be something else, especially if you have an abnormal liver context. Can transient, I mean, possibly you mean perfusion disorders, transient hepatic perfusion disorders, right? Differentials for infiltrative hemangiomatosis. It can, but in that case, most of the time, the transient perfusion disorders, they will not show on pre-contrast and non-contrast sequences, and it will not show an ADC or on diffusion weighted imaging. So that's a way to differentiate.
There was one final question. The last case patient had no complaints, just found in routine ultrasound. Was that the case?
Which case? This one?
Last case.
The number 4.
No, this case, the hemangioma.
Oh yeah. This case was just discovered like that. I don't remember exactly, but no complaint. No complaint. And I had one let's say final question for you. Maybe you can because we will not have time to discuss the final case, but maybe you can launch the last question that was corresponding to the case number 4, because this is something that can apply here too. The case number 4 was another case of hemangioma. So what complication is virtually non-existent in hepatic hemangioma? A thrombosis, a bleeding, the compression of surrounding organs, coagulation disorders, or pain. Which one is probably non-existent in this lesion? That is a very frequent lesion. It's the most frequent tisular, let's say, solid lesion in the liver.
So the results are coming in.
Yeah.
We'll give it a few more seconds.
Yes, of course.
Okay, more than 50% now. That's good. Okay, we'll close the poll here.
Yeah.
Here we go.
Okay, so pain comes first. Then we have thrombosis and everything else. So actually, what's interesting is the correct answer was picked by only one person. So that's nice to discuss that. So hemangioma are very frequent, and most of the time they have no complication. When they do, they can grow very big, and they can compress something around them. Okay, it's the stomach, whatever you want, and sometimes it's just a discomfort for the patients. So that's possible. Some of them will lead to pain. It's not really understood why. Some of them can, and you will see if you look in published papers, you will see series of hemangioma and various forms of treatment addressing those rare forms of painful hemangioma.
Very good. Thank you so much, Maxime. And apologies everyone again for the issues we experienced tonight. On the positive note, because of the way the platform is built, you will actually be able to log on to Collective Minds, access case number 4. I will post the link directly here in the chat. And from there, you can actually review the case and you can add a reply to the case. Should you have any questions about the case, Maxime, Martin, and all of you who are participating in this webinar series will be able to contribute and ask questions and learn from case number 4, which we didn't have time to review today. And so with that said, excellent presentation, Maxime, as always. And I mean, Martin, I'll leave it to you for some final remarks.
So if you want, you can review the images of the cases again in Collective Minds. Maxime's lecture will also be available on the site shortly. I think it's already available. The 2 previous sessions can also be reviewed, including the cases. Furthermore, I would like to thank Maxime again for this very instructive webinar. I hope you enjoyed it too, Maxime. And
a lot. And I do apologize for the problem of connection, which is entirely my fault.
Yeah.
But it was very fun, and thank you a lot to you, Martin, and to everybody else for setting this up. For everybody who joined, please feel free to send me any message, email, comments, insult if you want about my connection, and I will be glad to answer to you. And that's it.
Very good. And I guess unlike other webinars, you know, the discussion can continue on Collective Minds, and stay tuned. And there is more to come. We will welcome Martin on the adenoma topic in the end of next month. So
yeah, next month.
Thanks again, everyone.
Liver adenomas and together with mirror carpus. And also the one case of the hemangioma, I would also be glad to see the images on Collective Minds to maybe there's an alternative diagnosis of the hemangioma who was increasing in size. So maybe there's also a nice forum to get involved.
Share cases.
Okay, thank you very much.
Good.
And
thanks everyone. Have a good night, and don't forget to fill in the course evaluation or the webinar evaluation. We will send you the link shortly afterwards. Thanks so much. Have a good night. Stay tuned.
Bye-bye.
See you soon.
Bye everybody.